Good day. My name is Chris Salerno. I'm the Vice Chair of Surgery and the Chief of Cardiothoracic Surgery, as well as the Surgical Director of the Mechanical Circulatory Support Program and Heart Transplant Program at St. Vincent Hospital in Indianapolis. I'd like to thank IDM for the opportunity to speak, and I look forward to getting any feedback from the audience. My topic today is going to be DCD cardiac transplantation, and I believe that the time for this is a real clinical entity is now. So what is DCD, or donation after cardiac death? It is the procurement of viable organs after the withdrawal of life support and the cessation of cardiac function. The key difference between this and traditional brain death donors is there is now a period of warm ischemia time. Usually cardiac donation requires or allows for ischemic time of less than or equal to 30 minutes. The warm ischemic time is defined as the time that the systolic blood pressure is less than 50 or when peripheral oxygen saturation falls below 70% when either one of those events occurs to the application of the aortic cross clamp and the delivery of the cold cardioplegia. Now, honestly, this is not a new idea. When Christian Bernard performed the first heart transplant in 1967, this was performed using a DCD heart. However, it quickly fell out of favor with the initiation of brain death criteria, and the reason was it was thought that brain death donation would lead to improved outcomes. In the mid-2000s, a group at the University of Colorado in Denver began to first report resurgence of DCD donation in the pediatric population. Obviously, this is a challenging population to get donors for. And their initial results were, at least interestingly enough, to really get more centers to explore the possibility. The first real reports in the modern era came in about 2015, when groups both in Australia and the United Kingdom began reporting their outcomes using adult DCD heart transplantation. The initial reports were quite encouraging and suggested that the outcomes with DCD donors were near equivalent to those of similarly matched DBD or brain death donors. This is some data that was published from the Papworth group looking at a group of patients, the first 30 or so DCD hearts that they did, and compared it to like-minded brain death donors. And what you see is essentially equivalent survival both at 30 days and to discharge. There's really no statistically significant difference. I think what's interesting, if you look at the cardiac output that was measured in the DCD donors, it's actually slightly higher than what was in the DBD donors. So this was actually very encouraging, and there was subsequently a growth of DCD heart transplantation outside of the United States. So how is this done? There are three sort of described approaches to how this can be done. The first one is called a co-located donor. This is really something which is not part of current clinical practice, but it would involve having a DCD donor in one room and in very close proximity have the recipient, so that after there was a cessation of cardiac function, the heart would be procured and then immediately put into the recipient, and then allowing the cardiopulmonary bypass machine and the recipient itself to resuscitate the organ. This is currently falling out of fashion, and I don't know of any programs in the United States that are using this approach. The two other approaches, which I'll spend some more time on, are direct procurement and perfusion and normothermic regional perfusion. So what is direct procurement and perfusion? In this slide in the lower right-hand corner, you see a picture of the TransMedics OCS machine used to externally perfuse organs. So the first thing is, after withdrawal of life support, there's a cessation of life, and different OPOs and hospitals have requirements of what the standoff time would be. But after there's agreement that the patient has death by a normal definition, a sternotomy is performed. There's a required collection of blood that is needed to prime this system, a little over 1 liter. While that is being performed, a little bit of cardiac dissection is undertaken, the aortic cross clamp is applied, and ultimately there's a deliverance of normal cold cardioplegia. After the organ is procured, it is put on this TransMedics system, where there is ex vivo organ perfusion. So using the donor's blood, there is perfusion of the heart on this system. The system does allow measurement of some pressures and flow, and it does recollect the blood so that it can be used over and over again to perfuse the heart. The one downside is there is no functional assessment of cardiac function. So there is no way to measure cardiac output, ejection fraction, or any other the standard measurements of cardiac function. Instead, viability of the organ is assessed using a secondary biomarker, usually lactate, and trends in lactate help decide whether or not the organ could go on to be transplanted. There's about 80% of the organs procured go on to be used, and thus far in the world, there's about 270 DCD transplants have been done in this manner. The initial results suggest that whether using DCD donors or brain death donors and using them on this system to prolong ischemia time, the results are near what they are in the traditional brain death donor and cold storage technique. One of the exciting things about this technology is it may allow prolongation of ischemic time, which we normally believe to be about 4 hours, in excess of 6 hours. The other method, which is currently gaining some favor both in the United States and out, is normothermic regional perfusion. So again, this is a DCD situation where after withdrawal of life support, there is cessation of life and the standoff time which has been agreed to. There's a sternotomy which is performed, and immediately there's exclusion of the cerebral circulation, either using clamps or surgical staplers. The blood flow to the brain is permanently eliminated. Subsequently, the donor is placed on ECMO or cardiopulmonary bypass, and there is central cannulation, so aortic and right atrial cannulation. This allows reperfusion not only of the potential donor heart, but of all the organs in the body. The organs are perfused for some period of time, and while this is occurring, normal abdominal and thoracic organ dissection can be performed. Usually after about 30 minutes or so, there's an attempt to wean the donor from ECMO. This does allow a gross assessment of cardiac function. You could look at RV function, you could look a little bit at LV function, and at that time, if the procuring team was worried about the quality of the heart, you could still procure the other organs. So once there's agreement to move forward, the organs are then procured similar to a brain death donor. The aortic cross clamp is applied, cardioplegia is given, and the other organs are packed in ice, and procurement proceeds as routine. This method, as compared to the TransMedics approach, may allow for the use of older donors by allowing some assessment of donor function at the time of procurement, and appears to have a slightly greater conversion to transplantation. This is some exciting work here that was just published by the group at Vanderbilt, who has actually procured DCD organs in our OPO. This is the largest report in the U.S. for sure, and maybe in the world. We're using DCD donors with an NRP approach. They had 100% survival to 30 days. In my conversations with the senior author on this paper, Dr. Shaw, he actually has a sense that these organs perform better than similar brain death donors during the same time period. I think this is a very exciting approach, one that will probably bring greater prevalence in the United States. So will this have a real impact on the volume of heart transplants done both in the U.S. and worldwide? So it's been estimated that DCD donation in the U.S. alone could lead to approximately 500 to 600 additional heart transplants in the U.S. It's difficult to get the exact number, but there's currently a writing group from AATS which thinks that there's been about 400 DCD heart transplants, adult and pediatric, performed in the U.S. so far. Probably worldwide, there's another 500 or so, But when you look at certain regions of the world, in the UK alone, when they started DCD heart transplantation, the number of transplants performed annually in the UK went up 45%, and about 15% increase was seen in Australia. The slide to the right is simply looking at the potential number of DCD hearts which exist currently in the U.S. pool, and you see that even as the number of brain death donors increase, it's expected that we'll see an ongoing increase in DCD donation. So I think this can have a real impact on what we do, maybe as much as a 30% increase in the amount of transplants performed worldwide. Let's talk a little bit about DCD donor selection. As most of you are probably familiar, we have limits to what we can do to assess these organs prior to donation. Since these are still living patients when the conversation is undertaken, there may not be an echocardiogram performed, there may not be any other cardiac information. So some limitations are in place when we have organ selection. The first thing is there's an established Maastricht classification criteria looking at the types of DCD donors. And for heart donors only, we're talking about category 3 patients, where a controlled circulatory death is going to be the method of the donor passing. There's usually, and really for this to work, there has to be an intentional withdrawal of support with the procurement team present at the time of withdrawal support. The known age limit is still being somewhat debated. It's probably somewhere between 35 and 50. In the Vanderbilt data that I showed you previously, the oldest donor was 35. I think that's a very safe number. Some of the groups in Europe has gone as old as 50 years old. Obviously, these are not donors which we're going to allow previous cardiac surgery on, because the time to initiate either ECMO on the donor or to procure the heart would be greatly lengthened, and the warm ischemia time would be prolonged. And currently, it's thought that warm ischemia times beyond probably 30 to 40 minutes are not preferred. In general, these donors will be excluded for similar reasons. So if echo evidence is available, if there's a known low ejection fraction, probably less than 55%, known RV dysfunction or LVH, or a concern for prolonged warm ischemic time, the donors will likely be declined. How about DCD recipient selection? You know, I consider this very similar to conversations we've had about other high-risk donors. We don't really know if these are high-risk donors, but when we approached hepatitis C and some other donors, it first started with discussion at a multidisciplinary team where, based upon what the team thought the projected wait time and severity of illness for the recipient is, should we offer these patients participation in other routes to organ transplantation other than just brain death. I think all centers will have a separate consent form, and I think it's important to remember that this consenting for DCD donation should not exclude a recipient from brain death donation. And this was part of the Transmedic study, where all the patients who were in this study also had access to brain death donors. I think one of the biggest issues surrounding this is really ethics. So there have been significant objections raised by people that when they see reanimation of a heart, that this may invalidate the declaration of cardiac death, which is our definition of death in these donors. And I think most ethicists believe that this is not a strong position. For one thing, we would be treating the heart different from other organs. And it is, at the time of cardiac death, the cardiac function is inadequate to maintain brain perfusion to assure that the patient is not brain dead. And lastly, there is a real effort made, and I don't know anybody who is doing this without confidently having permanent cessation of blood flow to the brain. Some other issues that have been raised are family issues, whether or not it's appropriate to have the patient's family at the bedside when the DCD donor has withdrawal of life support. I think that's an individual hospital issue, and likely is one that will be debated from institution to institution. I think the people who procure these organs must honor whatever guidelines are in place by the local OPO and the hospital so that we preserve a sanctity of the event and respect for the process. And the last one is DCD heart donation should not be entertained if there's a risk of damaging the other organs and other potential recipients. So in summary, DCD heart transplantation has a long history. It's the beginning of heart transplantation. I think the data so far suggests that it is safe and effective, and the early results suggest that it is comparable in outcomes to brain death donation. We should see an increase in hearts because of this approach, maybe as high as 30%, and potentially even higher as we get more comfortable with the approach. And really, the optimal way to procure these organs is not known. And I believe ongoing studies and both multi-institution and individual institutional results will better refine the process. I'd like to thank you all for your attention, and thanks IDN for this opportunity.